Okay. Thank you very much for this kind invitation to the scientific committee. And Dr. Ahmed San has put an excellent argument. He's very charming. And I would like to get you guys just to keep an open mind before we judge which technology you'll vote for in the end. I have no disclosures. This is a very difficult topic to approach in any EP community. It's very polarizing. There's always going to be two camps. See already, you know. So the issue here is going to be, you know, who would you vote for, point by point versus single shot? Personally, I'm actually a point-by-point ablator, so this was a very emotionally difficult topic for me to even consider. But I had to keep an open mind when I was approaching this topic, and really we have to put emotions aside. And Dr. Ahmed tried to produce a lot of emotions and people to get them to affiliate with the point-by-point. Out of this room, how many people are point-by-point ablators, just out of interest? Okay, so as I expect, mainly the majority. But by the end of this case, I think, like myself, you guys will sway towards single shot, and for good reason. Now, like any process you're going to go through steps in design and technological advances, and you're going to have to reevaluate the current technology. What do we have, where are we going, and how are we going to produce something better, until you get to a stage that it's perfect and you have zero complications and safety, as Dr. Ahmed touched on and tried to show you that point by point is excellent and is pretty much free of any complications, is the contrary, that I'll try to highlight to you guys. Just a quick, this just shows you a summary of where we've come and where we've gone. And on the bottom, atrial fibrillation's been here for years, more than 30 plus years. We've been tackling this issue with thermal ablations. And I will talk you through some of the big trials. For many years, it's been a debate that's been between cryoablation and thermal and radiofrequency. This is meant to be, the next few slides are meant to be busy slides, just to show you that there's been lots of safety, efficacy data. Initially, what we wanted back in 2005 was just something quicker. They wanted something faster, safe, and they just wanted to get in and out. Because at the time, the mapping systems were very, not comparable to today, but took a lot, very time-consuming to make, difficult to be reproducible, and it still is, but that was one of the main drivers towards them. Later on, 2017, they started to really show that by, how far can we push the temperatures and still achieve good outcomes. Efficacy, lots of trials showing good efficacy for the cryo. They got more brave. They said, okay, let's go head-to-head with the point-by-point ablators. And as you guys remember, in 2016, fire and ice caused a big debate, and two camps were created and saying, hey guys, we're non-inferior anymore. We're going to start setting up cryoablation labs now rather than going point by point. And then, of course, the counter-argument point said, hey, we don't have contact force. We need you to redo this trial. And I don't think Dr. Andrade expected the outcome of I know this is maybe in your favor, Dr. Ahmed, you're welcome, so I just wanted to put this as a true point-by-point ablator. This really showed that there was finally some separation between point-by-point efficacy versus the versus the cryoablation, and you could see in the bottom left there that radiofrequency in terms of atrial arrhythmias recurrence was much less, because we got really good. We got to contact force now, we created things, but outcomes were not exceeding more, we weren't achieving anything higher than the 70s in terms of the persistent outcomes. And to achieve that, you really need transmurality, and that's where the difficulty comes in. And unfortunately, you're a bit disadvantaged, Mr. Ahmed, with the technology that you have. And I'd like to quote my good Albert Einstein here. The definition of insanity is doing the same thing over and over again and expecting different results. We've been doing it for 30 years now, and yet, finally, once we finally got a bit of separation, radiofrequency ablation felt a bit superior to thermal, to the cryoablation, suddenly this beast comes out of nowhere, pulsed field ablation. Dr. Ahmed made life easier. He highlighted certain aspects to you of the trials that I'm going to show you now. But I want to focus you on a few things, and this is real-world data. One thing you have to remember with these really good trials with the point-by-point and radiofrequency ablation is these are really, really high-volume centers that are producing these outcomes. If you were to take radiofrequency ablation point-by-point across the MENA region with lower volumes across all centers, I would like to see that registry. I would like to see our efficacy. I would like to see the reproducibility in those centers. You're not going to find these results. Whereas this is real-world data, observational, across 24 centers where they had 90 operators. This is new technology. They were still finding their way around it, and yet they were producing 82, and a lot of them, as Dr. Fahad commented earlier in the last talk, about using sedation. 82% in Europe were under sedation rather than GA. So that's another thing to factor into the cost that Dr. Ahmed didn't mention to you guys, because the patient will stay overnight and rehospitalizations. We'll get to that later, Ahmed. All right, so safety, look at the bottom left. There was really an excellent signal of tissue sparing. The Euphoria trial, this is another big observational study, more than 1,200 patients, 42 operators, 7 high-volume centers, and again, excellent reproducibility, great efficacy. And then we decided, okay, it's time to go head-to-head with radiofrequency. And we went with the Advent trial that he highlighted a few points for us. Now, with regards to the Advent trial, it was randomized to thermal, where we decided, you know what, cryo, we're not going to count you a single shot, go across to the other side of the fence, join the thermal group. And it's because we wanted to separate two technologies, thermal versus PFA. And that's where, and looking at the different endpoints, safety and efficacy, of course, meticulously, they separated the two groups, and if you can see here, they're really very well matched in terms of CHAS-VASc scores, age, and the outcomes. They found that non-inferiority in terms of the safety endpoints, superiority with the secondary endpoints, which I'll touch on in a moment, and non-inferiority in terms of efficacy. Dr. Ahmed showed you these slides, and I think it's not unexpected, these results. I think we really are really good at tackling atrial fibrillation with the technology we have, both in point-by-point and in single shot. But I think we're underestimating how hard it is to treat AF. AF is not like we're treating it the same as if it's an accessory pathway or a slow pathway, and that's the mistake we're making, because we're letting the wider community, that's not the non-EP community, think that it's something that we can isolate just with a single shot, and that's wrong. It's actually a syndrome that's very difficult to manage. I'll just power through some of these last few slides. I want to focus on safety now in the end. This is a trial that showed cardiac MRI images comparing PFA and versus thermal and radiofrequency ablation. They took shots before the trial started, before the ablation started, within 3 hours, and at 3 months. And it shows you that the PFA throughout these cardiac MRIs did not affect the tissue. It was very selective, didn't affect the esophagus. And of course, when you don't have high volumes and you're not producing and you're not doing a lot of cases, the biggest concern you have is atrioesophageal fistula. That is fatal, okay? And what's scary is that 43% they found in 43% of the cases had an injury to the esophagus post the ablation. Even though we came out of the study, the case, thinking we didn't do any harm, actually we have caused edema and esophageal injury. So the key point with this one is it does not induce any signs of esophageal injury. Now, what about the pulmonary vein stenosis? We looked at the Impulse trial, PFCAT, and in the end, we compared there was well matched to the RF groups, and unfortunately for what Dr. Ahmed didn't show you is that there's significant narrowing with the PFA, and this was just to demonstrate to you just visually. Look at the before baseline and 3 month shots. Look at how much significant stenosis that can cause, and it's not surprising, right? You're chasing a signal inside there, and you keep going in further. The person next to you says, just another shot inside, and you're going in, and you suddenly walk out of there with 100 lesions, and you think, oh my gosh, what happened? Okay, so again, safety. Safety is the key. Now, if I haven't convinced you yet, I honestly don't have to. The companies have already made a decision, by the way. They've invested in the other direction. They've left the older technology. They know that we want 3D mapping incorporated. J&J have introduced the Varipulse, just got approval in Europe. Medtronic just invested $1 billion in Affera. they're now jumping into the field, guys. They've created their PFA balloon. Abbott Volt study. I know we're all jealous of the guys in Europe. They're just showing us all these amazing images, going in there, 3D mapping, incorporated with the balloon catheters. So my argument to you in the end here now is, how can you turn down a technology that's now more efficacious, has a safety profile that's superior and tissue selective, very forgiving? In terms of reproducibility and procedural duration, this is where this is a game changer. You don't have to have the hands of Dr. Ahmed Salem or Dr. Fahad, Dr. Naeem here to actually get excellent outcomes. You can be as good as anyone. And just so long as you can do a safe transeptal puncture, you will be able to produce excellent results. Thank you for your time, guys, and I look forward to discussing a few more points.